Hello, everyone, and welcome to the webinar for SAICM as a side event for tackling harmful chemicals in the healthcare sector. My name is Susan Wilburn. I'm the International Sustainability Director for Healthcare Without Harm, and I will be your moderator today. I am also the health sector civil society representative to the Bureau of the Strategic Approach to Chemicals Management. SAICM is mandated by UN Environment and endorsed by the Johannesburg World Summit on Sustainable Development, now almost 20 years ago in 2002, became alive with the Dubai Declaration in 2006 that says by 2020, by last year, chemicals are used and produced in ways that lead to the minimization of significant adverse effects on human health and the environment. We are now in the process of developing the successor agreement to SAICM, which was to sunset in 2020 and is continuing until the International Conference on Chemicals Management, ICCM 5, which has yet to be finally scheduled. It was postponed once and postponed a second time. That we thought we would be meeting in July of this year, and looking forward to being able to see all of you on this call in person at ICCM 5 when we finalize the successor agreement to the new instrument. In 2012, SAICM and then implemented in 2013 a health sector strategy. And today we're talking about one of the components of the health sector strategy, and that is the sound management of chemicals in healthcare settings. There are many hazardous chemicals that we use in healthcare settings, some of which are therapeutic for the patients to whom they're exposed and are hazardous to the workers who are also exposed to them. Others are by their nature on purpose hazardous, such as disinfectants, which is the subject of one of the presentations today. And we can choose safer and less toxic disinfectants that are equally effective. So that SAICM health sector strategy was developed in order to engage health sector participants in the process of SAICM, which is a multi-sectoral and multi-stakeholder process for non-legally binding activities that in many cases lead to legally binding outcomes, such as in the case of the elimination of lead in paint, one of what was an emerging policy issue and has become a very important SAICM initiative. Also, in partnership with SAICM, WHO and the International Labor Organization, the Food and Agriculture Organization, together with UN Environment, are key international agency partners. And WHO, through the World Health Assembly in 2017, requested that WHO develop a roadmap on chemicals, in part as part of the contribution to the SAICM overall objective. And our first speaker today will be the head of chemicals for the World Health Organization, Carolyn Vickers, who will be talking more about the successes in the implementation of the roadmap. At Healthcare Without Harm, we've been working on chemicals of concern to health and the environment for over 25 years. And earlier this year, we published this document that you see on screen about chemicals of concern that are used in healthcare settings. And we developed a document which is a consolidated list of chemicals of high concern from many authoritative lists, including the environmental instruments, the conventions, the WHO Top 10, the International Agency for Research on Cancer, and the major EU regulation on chemicals REACH, and the California Proposition 65 on reproductive hazards. This document summarizes the chemicals that are used in healthcare that are listed by these authoritative bodies and provides case studies from of health facility eliminating and substituting chemicals of high concern from the supply chain for those with less toxic effects. Thank you all for joining us today. I'm going to now introduce our 4 speakers in order and then turn the microphone and the cameras hopefully over to those speakers. Our first speaker again is Carolyn Vickers, who is the head of the Chemical Safety and Health Unit at the World Health Organization in the Department of Environment, Climate Change and Health at WHO headquarters in Geneva. The Chemicals Unit coordinates the implementation of the Chemicals Roadmap, involving global networks of ministries of health, public health institutions, and other stakeholders. The unit develops WHO norms, guidances, tools, and approaches to support countries in their work to manage chemicals. Prior to joining WHO, about the same time as SAICM was being adopted, Carolyn has held various positions in the Australian government related to the regulation of industrial chemicals, pesticides, and occupational health and safety. Our next speaker will be Darota Napierska, the Chemical Policy and Projects Officer with Healthcare Without Harm. Darota is responsible for Healthcare Without Harm Europe's work on safer chemicals, which includes improving awareness of the health and environmental risks posed by key chemicals of concern used in health products, identifying priorities for action and opportunities for substitution. Darota has a PhD in biomedical sciences and is a registered toxicologist in Europe. Prior to joining Healthcare Without Harm, she worked as an expert for the European Commission in DG JRC and as a researcher at the Department of Public Health at the Catholic University Leuven in Belgium. Darota will be talking about disinfectants. The next speaker will be Professor Aleister Boxall, who is a professor in environmental science at the University of York in the UK. Aleister's research focuses on the understanding emerging and future ecological and health risks posed by chemical contaminants in the natural environment. His team coordinates the global monitoring of pharmaceuticals project that aims to better understand the extent and drivers of the medicinal contamination of fresh water worldwide. Aleister regularly advises national and international organizations on issues related to chemical impacts on the environment and has published extensively on the topic of emerging contaminants in the environment. Professor Boxall will be talking with us about what was the emerging policy issue on environmentally persistent pharmaceutical pollutants. Welcome, Professor Boxall. Our last speaker will be Dr. Laura Vandenberg, who is the Associate Professor at the University of Massachusetts in Amherst in the United States. Laura obtained her Bachelor of Science from Cornell University in 2003 and her PhD from Tufts School of Medicine in 2007. Dr. Vandenberg has been a member of the faculty at the UMass School of Public Health and Health Sciences since 2013. Her research explores how early life exposures to chemicals and chemical mixtures can predispose individuals to diseases that manifest later in life, and addresses the impact of low doses of chemicals during critical windows of development. She is specifically interested in endocrine disruptors and co-authored the 2020 IPEN and Endocrine Society's report on plastics, EDCs, and health. And Laura will be speaking to us today on plastics. Welcome to all the speakers, and I would like to make a special welcome and turn over the microphone to Carolyn Vickers.
Thanks very much, Susan, and hello, everyone. Give me one moment while I start my presentation.
And while Carolyn is sharing her screen, I will remind you all that please put your questions in the chat. We will have an opportunity after all 4 speakers present for questions, answers, and discussion. If you have some quick clarifying questions about one of the speakers' presentations, please also put it in the chat and we'll try to address that immediately.
Good, thanks a lot, Susan. Just want to check that you can see the presentation fine.
I am not
No.
seeing the presentation.
Okay.
Here, it has now appeared.
Yeah, very sorry about this. I just want to check that you can see that it's displaying the full presentation now.
Yes,
Can you see that now?
yes.
Excellent, thanks a lot. We all still have a lot to learn, obviously. Hello, everyone. What I'm going to talk to you about today is about the roadmap, which Susan briefly introduced a few moments ago. But first of all, I want to backtrack and say, why are we all here? Why did WHO develop the roadmap? What is the issue? There is not a lot known about the health impacts of chemicals, primarily because it's quite difficult to associate an exposure with an effect, particularly with, for example, the NCDs. Acute poisoning is fairly well documented, but not some of the chronic effects. But what we do know is from in 2002 that there were at least 1.3 million deaths attributable to just a small number of chemicals where there are data. And I'm talking about chemicals such as lead, some pesticides exposures. But we don't have a handle on the exposure from some significant sources. For example, mercury, there isn't a burden of disease estimate. Still, based on what we know, in 2016, the number had risen to 1.6 million. And I'd like to mention also that they will have an update at the Berlin Forum, which I hope many of you will attend, which is starting tomorrow. In the ministerial segment, the Director General of WHO will release the new data from the year 2019. That is the data on deaths and effects in 2019, which has been collected and summarized now in 2020. But what we can see from the figures is that the burden of disease attributable to chemicals is increasing, and that it isn't the whole picture because people are exposed to many more chemicals in their daily lives. What's the foundation of health sector engagement? Well, in terms of WHO, health ministries, and the global community, obviously people have been working on this issue for a very, very long time, decades, more than a century. But just to identify
Carolyn,
some of the, yes.
Sorry, your slides are off on the side of the screen because we're seeing the speaker note slide. If you can change the display.
Is that better now?
Now we only see your slide, but it is wide beyond the screen. I don't know if there's a way to.
Perhaps somebody who's got the slides could, at Healthcare Without Harm, if you would like to share them, I can just speak to them. We could try it that way if you like. It's something to do with the Zoom setup.
Give me a second. I'll do that.
Sorry, everybody.
Thank you. Apologies to you, Carolyn.
No apologies to everyone. Do you want me to stop sharing my screen?
Yes.
Mm-hmm. Okay.
Okay, so I'll share my screen now. 1 second, it's loading.
And just while that's happening, I can continue on to say that, of course, health impacts of chemicals have been known for a very long time, from the identification of hazards such as mercury in hatters, white lead, etc. But in recent times, if you move to the slide after the next one, yes, thank you. In terms of WHO's involvement, the most recent involvement that relates to SAICM was a resolution that acknowledged SAICM and urged member states to implement it. Then in 2016, the chemicals roadmap was requested by the Health Assembly, adopted in 2017. And we've had regular reporting back to the Health Assembly because of the delay, the postponement of the International Conference on Chemicals Management. We'll continue to report on implementation of the roadmap as well as actions that we've undertaken as the WHO Secretariat to update the roadmap in light of the outcomes of ICCM 5. We'll report on that in 2023. So we can go to next. So here we see the roadmap. It was developed to support the health sector at all levels, national, regional, and international. It's not only aimed at member states, it's also aimed at all stakeholders that play a role in implementing the health sector strategy, health sector ministries, health sector actors, and also other agencies. It recognises SAICM and the health sector strategy that Susan mentioned previously. Next, please. So you would have seen on the page before the icons for the SDGs. The health sector strategy in particular links to obviously the health goal and the target, 3.9, that by 2020 substantially reduce the number of deaths and illnesses from hazardous chemicals and air, water and soil pollution and contamination. The strategy references the contamination of drinking water target 6.3 and also the main SAICM target 12.4, which is essentially moving into the SDG framework, the 2020 goal that had been established previously. So what does the roadmap cover? When you look inside, you'll see it lists quite a number of concrete actions that the health sector plays a leading role in implementing. It's organised into 4 areas: risk reduction, knowledge and evidence, institutional capacity, leadership and coordination. And these are activities where the health sector has a lead or supporting role, recognising the need for multi-sectoral cooperation. And it also identifies the actor, the lead actor. So MS, member states, all WHO Secretariat. So we've already heard positive feedback by about the roadmap, and other sectors are interested in also perhaps having a similar tool to plan and track their contributions to SAICM. Moving to actions that we have specifically about the healthcare setting, under the risk reduction activities, we have a number. There's a column which addresses healthy healthcare settings, addressed to member states, but also other actors will of course be involved in contributing to and implementing these activities, providing guidance for healthcare settings to promote and facilitate the use of safer alternatives, also looking at waste management, awareness campaigns, and in particular, we've identified guidance on the use of mercury in healthcare, etc., because of the Minamata Convention on Mercury, which was quite an important convention where the health sector has an important role to play. How do we use it? To identify areas for further action, advocate for action by decision makers, feed into national planning. People have used it to get funding for activities. So countries have used it, and also other stakeholders, to identify where there are gaps in their activities and to make a plan of action for the short, medium or longer term. And then the roadmap activities that they've selected can be communicated to other sectors. It enables people to communicate the activities that they're implementing in a harmonized way so that we can put together, for example, where people are working on particular activities, where there are common interests, etc. So one of the main things that WHO has done is to establish a global chemicals and health network. That's a network of ministries of health, and we're working with them to implement the roadmap. 75 member states have joined so far. Now I'm going to show you just a few examples of some of the products that we're working on that relate to the topic of the webinar today. So recently, WHO released some guidance for climate resilient and environmentally sustainable healthcare facilities. This includes aspects of chemicals management alongside the others, because we're really looking at making sure that this is usable from the healthcare facility point of view. And chemicals, of course, is both a cross-cutting issue, but also an issue that's never addressed in isolation. You don't go in and look, you see many issues in a setting, in a population, in a place, or in a healthcare facility and just look at the chemical issues. There are many issues that people in that place would need to address in a coordinated and organized fashion. And so this provides a tool for people to do that. Antimicrobial resistance. I know there'll be some more discussion about this later. WHO coordinates the global response on AMR and reports to the UN General Assembly. This is simply a picture of one of the activities that we undertake each year, which is to lead World Antimicrobial Awareness Week. This is the picture from 2010. And it's one of the areas where WHO is extremely active. Just turning back to the mercury issue, something that's very important for healthcare facilities is that they do need to stop the import, export and manufacture of mercury-containing thermometers and sphygmomanometers. The deadline under the Minamata Convention was in fact 2020, but there's still quite a lot of work to be done there, and we're supporting countries with guidance and also with funds to enable them to complete their work in this area. Many of you will be familiar with the WHO model lists of essential medicines. It's really important that, as well as providing guidance about where the hazards are and what to avoid, that we also address what are the safe and effective medicines, to avoid unnecessary use of medicines, to avoid expense that's not required, and also to make sure that the best choices are being made by countries and others in the healthcare facilities. So this is an important aspect, sort of proactive aspect as well. COVID, of course, is all on our minds, and we're going to hear some more about disinfection, but one of the early guidances that WHO released was about cleaning and disinfection of environmental surfaces, including in healthcare facilities. And it provided advice on the efficacy, which products are necessary, the circumstances that are necessary, and also, for example, provided early advice that dissuaded people from, wide-scale spraying of disinfectants, and even disinfection of people was happening quite early on, and we don't see that so much now. So this kind of guidance, being able to get that out quickly is quite important. So this is my second last slide, I think. I hope I'm keeping to time, Susan. The implementation of the roadmap, it's not just about what WHO is doing. In fact, the bulk of the work is going to be done by member states and other stakeholders. All of you colleagues that are on the webinar today will be playing a role. And how we've been communicating, sharing work on this is by inviting countries and other stakeholders to develop case studies. So if you'd like to submit any case studies from your organization about work you've done to implement the roadmap, we're publishing a series of those. What we've seen from the case studies so far is that they highlight the importance for health of sound management of chemicals in many varied settings, schools, healthcare facilities, etc. It shows the different lead roles that the health sector can play and the benefits of connecting with other sectors. And it really affirms the presence of multiple opportunities to better manage chemicals. So it really illustrates different areas where countries and others can act to address sound management of chemicals and waste. So finally, thanks very much for your attention today and patience with the little problem with the presentation at the beginning. Just want to mention some tool that's available for you, as well as the roadmap. We have a workbook, which is a tool that you can use to work through the activities of the roadmap in a kind of a workshop setting with your colleagues to identify activities that you would like to implement. So thanks very much, everybody, and back to you, Susan.
Thank you very much, Carolyn Vickers from the World Health Organization headquarters in Geneva. And what we know through the SAICM meetings is that many sectors have identified the WHO roadmap on chemicals as a great example, if not the best example, of an approach for a sector to manage chemicals, both in their own use as well as providing leadership for health professionals to assess and address chemical hazards. I'd now like to again welcome Darota Napierska, the Chemical Policy and Projects Officer for Healthcare Without Harm, who is going to speak more about the SAICM 2.0 project on disinfectants. Over to you, Darota. Thank you.
Hello, everyone. I hope you can hear me and you can see my presentation.
Yes, both well.
Thank you. I just wanted to be sure, just to avoid any misunderstanding. So once again, hello everyone, welcome to this webinar. The subject of our presentation will be chemical disinfection, and I will focus not really on this discussion that's going nowadays, as you know, within the COVID-19, on more of use disinfection in the context of threats posed by pathogens. But I would really like to focus on how practical application of chemical disinfectants could be improved to make them more safe, to minimize negative impacts on human health and environment. So I will start with a very, very short introduction to disinfectants in healthcare, and then I would like to inform you about our project promoting safer disinfectants in the sector, introduce the widest database, show a summary of the survey on the procurement of disinfectants within healthcare organizations across the globe, and finally I will reflect on the outcomes of the report we published last year, and I will share also some information about more recent and future developments. It is important to emphasize that while the use of disinfectants has dramatically increased because of outbreak of COVID-19 across the whole world, the healthcare sector has always been one of the key users of these products. And even if disinfectants and cleaning are sector's daily routine, unfortunately, those two are still a little bit confused, and moreover, many different definitions actually exist, which may resemble each other, but are not completely identical. So just to clarify that while the process and the goal of cleaning is to remove the dirt deposited on the surfaces through mechanical, physical, or chemical means, disinfection, on the other hand, is the process, mainly chemical, but actually it also can be physical, which destroys, we always say, kill the microorganisms and remove them from the surfaces. And it's very important also to emphasize that the cleaning is actually considered really the essential step prior to any disinfection process. And in fact, in many situations in the hospitals, cleaning with detergent followed by rinsing and drying is sufficient to prevent the spread of infection. In some other situations, disinfectants are definitely necessary. And a good practice dictates to always perform a careful assessment to determine level of cleaning or disinfection required. The topic on disinfection is really complex and requires a good understanding of aspects like disinfectant categories, active substances used for disinfection, field of application, different practices in human healthcare settings, also the emerging health risk and environmental risk linked to disinfection. And we don't really have time today to dive into those topics more in detail, However, all those crucial aspects have been discussed by an expert panel of hygienists and infection preventionists, infection control practitioners and microbiologists from Austria, France, Germany, India, and Singapore. And I therefore warmly recommend to look into the paper that you can see on the screen and below on the slide. And this paper has been actually published quite recently in December last year, where a lot of this information is discussed, and also the paper contains many useful conclusions and recommendations. So there's absolutely no doubt that disinfectants in healthcare settings are essential to prevent cross-contamination, outbreaks of diseases, and hospital-acquired infection. And the European Centre for Disease and Prevention and Control identified antimicrobial resistant and healthcare-associated infections as very serious public health problems, not only in Europe, but globally. And according to the agency, approximately 4 million patients acquired those healthcare-associated infections only in the EU. There are 4 million patients, and approximately 37,000 of deaths directly result from those infections. So while disinfectants in healthcare settings are essential, well, unfortunately, the biocidal active substances present in disinfectants pose other a series of hazards. They are related to serious occupational health hazards. We know that many chemicals can cause cancer, reproductive disorders, occupational asthma, eye and skin irritation, etc. And biocides are also linked to environmental threats and can contribute to the spread of antimicrobial resistance. And when it comes to disinfectants, there's a certain hierarchy in criteria to choose them. So first, what counts, and that is actually also extremely important when we are fighting today against coronavirus. So it's actually first what counts is really their antimicrobial efficacy. So they have to do the work they're applied for. And this efficacy should be really evidence-based. So in Europe, this is done by passing a certain standard test. Then we want to minimize negative impacts on occupational health. We want to minimize negative impacts on the environment as much as possible. And of course, this is something actually still important, we cannot ignore. We want to keep those products at an affordable price. So while there was, I think many people actually working within the healthcare sector were asking themselves how the sector, everyday user of disinfectants, can prevent or at least minimize all those negative impacts on human and environment. And to address this question, we were working for 2 years on the pilot project promoting the use of safer and more environmentally friendly disinfectants that can substitute those more harmful, and of course without compromising hygienic and occupational health standards. And so-called SAICM 2.0 project addressed the health environmental problems related to disinfectants using healthcare at local, regional, and national levels by engaging a broad range of stakeholders in hospitals and nursing homes. But before I will come to the results of the survey that was performed between these mentioned stakeholders, I would like to say that the core of this project work relied on the hazard analysis and product benchmarking that built upon the successful VNS data for disinfectants. So this is this WIDIS database. This database has been developed by the Vienna City Administration to directly address the difficulties in choosing appropriate disinfectants, while at the same time considering the wider health and environmental impacts. Database contain correctly data on more than 200 ingredients and more than 300 different products. And all public authorities are using it to select disinfectants with the lowest hazard potential. And in fact, about 90% of disinfectants used currently by the Viennese Hospital Association are also from this list. So our SAICM 2.0 project aimed to broaden the application of this database, of the methodology used by this database to other countries. At the beginning of the project, Healthcare Without Harm launched a survey aimed at gathering information on the practices of procurement and application of disinfectants within healthcare organizations. The survey was made available in 5 different languages and collected 87 responses from 19 countries across the globe. Within their organizations, the responders mainly had roles related to environmental protection, infection protection and control, and procurement. And the result of the survey clearly showed that when setting procurement criteria, when hospitals are buying disinfectants, that's really product price and efficacy, followed by occupational health, and staff's feedback proved to be decisive factors for most of the hospitals involved in the project. And that was followed by environmental health factors and national standards. After the survey, 172 products were identified, hazard information related to their ingredients were completed using the methodology from Vickers database. So just very shortly, in practice, it means that we apply so-called ABC categorization. So this hazard was ranked and differentiated in 3 different categories: A, high concern; B, considerable concern; and C, low concern. And after this work has been done, 9 hospitals were selected for further tailored support to identify less hazardous alternatives for disinfectants used in those hospitals. And finally, 6 studies has been further elaborated regarding the product recommended for substitution, identification and assessment of potential alternatives, product benchmarking, and learning outcomes. And all this work resulted in the Healthcare Without Harm Europe recent report promoting safer disinfectants in the healthcare sector, which was published by the end of last year and is available. It can be found on our website. What you can find in this report are suggestions for product selection strategies. So it's very well, actually, it's very technical information. It's very easy to apply this methodology and mentioned to prioritize the products. There is also the case studies I just mentioned are described in detail. We also included brief summary regarding non-chemical alternative solutions and innovation in the field of sustainable disinfectants practices, and as well as a number of recommendations. Learned is that globally there are still quite serious inconsistencies when it comes to hazard communications, and different information disclosure practices exist among countries. One of the problems is that actually still many countries have not implemented those GHS, so global harmonization system for the hazard communication for the chemicals. Also globally, there are still quite many biocides and disinfectant products on the market that have not yet been sufficiently investigated, and that also actually applies to the EU market. And we notice really a need for a better understanding and applying of a concept of sustainable use. So that is how we understand when biocides are really only used when deemed truly necessary. And this prudent use of biocide is really emerging in our fight against emerging antimicrobial resistance. We learned from the city of Vienna that access to information, improved regulation, and setting sustainability criteria for public procurement has really changed the market for disinfectant products in Austria. So we can summarize that our report provides a tool for hazard identification, product selection, and procurement decision which is thought to be applicable worldwide. It also highlights areas of improvements and actions that should be taken at different levels, such as to address the need of hospitals and procurers to identify safer alternatives, improve the current regulatory policy framework, promote sustainable procurement practices, encourage responsible business practices, and foster innovation in the field of sustainable disinfection practices. Based on the project outcomes, Healthcare Without Harm regional partners initiated work on safer disinfection through a global procurement project implemented together with the United Nations program, so-called SHE project, Sustainable Health Procurement. And hopefully, this project will scale up the SAICM to zero project efforts. I would also like to draw your attention that Healthcare Without Harm Europe launched a new initiative called Healthcare Market Transformation Network, which aims at development of harmonized sustainable procurement criteria tailored to products and services purchased by the healthcare sector. And the work on disinfectants will be facilitated through a dedicated working group and reference group, which will support a dialogue among procurers, health professionals, and suppliers. And also, in addition, although the project did not really analyze in detail non-chemical alternatives, we see that there's a growing interest on these subjects, and we are also welcoming further evidence about the safety and effectiveness of non-chemical solutions, as they actually could really complement approaches to prevent the spreading of infection in healthcare settings while minimizing the use of biocide. And finally, I would like to express our gratitude to many people that supported this work, and of course to all hospitals that participated in the project. We also acknowledge the financial support from the European Commission, the German Federal Ministry for the Environment, Nature Conservation and Nuclear Safety, and the German Environment Agency. So thank you very much for your attention.
Thank you very much, Darota, for your presentation. And a reminder to all that if you have questions for any of the speakers, please put the questions in the chat. And if you are interested in participating in or learning more about the market and supply chain transformation activities, I think that the colleagues in Healthcare Without Harm Europe would be happy to hear from you. Our next speaker is Professor Aleister Boxall, the professor in environmental sciences from the University of York. Over to you and welcome.
Hello, everybody. It's great to be here this afternoon talking to you. And I'd like to thank Jean-Yves for inviting me to present. What I'm going to do in the next 15 minutes is just give you a little bit of an overview of the work we've been doing, looking at pharmaceutical pollution across the globe. And before I start, I'd just like to acknowledge my co-authors. So John Wilkinson is a postdoc in my group, and Alejandra is a PhD student in my group, and I'll be drawing on work from both of them in my presentation. As a society, we use somewhere around 2,000 different pharmaceutical active ingredients. And when we use these active ingredients, obviously, we're using them to treat a sickness or prevent an illness, and we don't really think about what happens to them following use. And this is really what I'm going to talk about today, and this is something that we at York have been working on now for quite a long time, looking at sort of what happens to pharmaceuticals post-use. And what I got here is just a bit of a back of an envelope calculation of what happens to pharmaceuticals in the UK based on data that we've pulled together over the years. So in the UK, we use roughly about 13,500 tons of active pharmaceutical ingredients each year. So that's prescribed by the doctors, so that doesn't include over-the-counter medicines. Of that, about 2,800 tons aren't used, so they'll probably end up in the trash, which seems to be the primary route of disposal for unused medicines in the UK. Some of it might get back to the pharmacist, and some of that might be flushed down the toilet. And of the stuff we use, about 5,000 tonnes are metabolized by our body, so they'll be converted into other substances. And what that means is about 6,000 tonnes are actually not metabolized, and they'll be excreted in our urine and feces. And in the UK, what will happen to that material then is it will be released to the wastewater treatment system. So this is just a picture of one of the old Victorian sewers in London. So you've got the wastewater flowing through that sewer, and if we took a sample of that water, we would find residues of pharmaceuticals in use by the population of London. Now that material will be, again, in the UK, it will be transported to some form of treatment. So this is one of the types of treatment that we use in the UK. It's called a trickling filter. And basically what we're doing here is we're using bacteria to clean up the sewage. And these are primarily designed to pull out the bulk organics in the wastewater before the water is then emitted out into the environment. Now, the problem with these treatment systems is that they were designed for treating sewage. They were not designed for treating pharmaceuticals. So what we find is that many pharmaceutical active ingredients will pass through these systems and then enter the freshwater environment. So this is a picture of my local river. So this is the river Ouse in York. And over the years, we've been looking at the occurrence of a whole range of different pharmaceuticals in the river Ouse in York. So this link between the use of pharmaceuticals and the presence of the pharmaceuticals in the environment was really recognised about 35 years ago. And since then, quite a lot of work has been done to look at the occurrence of pharmaceuticals, both in aquatic systems and also in soil systems receiving either wastewater irrigation or biosolids from wastewater treatment processes. And in 2017, this paper was published. And in that paper, what they attempted to do was begin to look at what information was available in the published literature on the occurrence of pharmaceuticals around the globe. So what we have here is we have a map of the world, and countries are coloured based on the level of data that are available on pharmaceuticals in water bodies in each of those countries. So if you've got a country that is dark red, that means that somewhere between 100 and 200 active ingredients have been monitored in aquatic systems in those countries. Whereas we move to countries coloured in yellow, they're countries where only a handful of pharmaceuticals have been monitored. You can also see that we've got quite a number of countries actually shaded grey. And these are countries where there's no data at all, or there wasn't any data at all in 2017 on the level of pharmaceutical pollution. So a couple of years ago, what we decided to do was try and begin to address this lack of data on the presence of pharmaceuticals in river systems around the world. And we kicked off what was called the Global Pharmaceutical Monitoring Project. This is a project where we've worked with collaborators around the world, and we've taken samples of river waters at over 1,000 sites and analysed those for 61 pharmaceuticals. And we've managed now to sort of look at concentrations in river systems in 104 countries. The way we've done it is we've developed sampling kits. So you can see on the left there a photo of the sampling kit. So this kit includes a bucket, it includes syringe filters, it includes vials. So it's all the material that our collaborators need to go out to their local river system to take samples of the water. And what they'll do is they'll then sample the water, they'll freeze those samples, and then it will be shipped by DHL back to York, where we'll analyse them using liquid chromatography and mass spectrometry. And what I'm going to do in the next few slides is just give you a little bit of a feel for the data that had been generated from the study. So I think, as you can imagine, we were looking at 104 countries, about 1,100 sampling locations across those countries and 61 pharmaceuticals. So we've developed quite a very large data set on levels of pharmaceuticals around the world. What we have in this map then is the total concentrations, or the mean total concentrations, of the 61 pharmaceuticals that we detect by country. So if a country is shaded blue, then the concentrations are down towards the lower end of the scale. If they're shaded red, they're up to the higher end of the scale. And straight away from this, you can see that in the 2017 country, many countries that were grey in that study, we've now monitored. So we now have data for countries that haven't been monitored before. So we have data for 33 countries that hadn't been looked at before. And I think what's interesting is the countries that we are seeing highest concentrations of pollution tend to be the countries that haven't received as much focus in terms of monitoring in the past. What we can do is we can begin to beam in on the different river systems. So these are the top 25 most contaminated river systems that we looked at in the study. So the most polluted system was in Pakistan, in Lahore, and then the second was in Bolivia, then that's in La Paz, and then we have Addis Ababa in Ethiopia. You can see from this list that the most polluted systems are generally in Africa, Asia, and Latin America. But you can also see that there are European systems in the list there. So number 14, we have Madrid in Spain. So this was a river going through the center of Madrid. You can see that we have Dallas in the US at number 24, and then a UK site. So this is Glasgow, which is in Scotland, number 25 there. So what we're finding from the study is that pretty much pharmaceuticals are everywhere in terms of river systems. We are seeing the most polluted systems in the more sort of southern hemisphere, so in Africa, Latin America, areas of Asia. They tend to be in low and lower middle income countries. And that then raises the issue, well, what is the impact on the ecology and also on potentially human health? We know that pharmaceuticals are biologically active molecules, so we would expect that if these things occur in the environment, there could be negative effects. So what we've done with the data is we've pulled together for each of the 61 pharmaceuticals, we pulled together information on the ecotoxicology of the pharmaceuticals to derive predicted no effect concentrations for each of those compounds. But we've also taken some of the target values developed by the Antimicrobial Resistance Industry Alliance to compare those AMR target values with concentrations of the antimicrobials. And we have the results of that analysis here. So we've broken this down by continents. The blue bars correspond to compounds where there's an exceedance of the AMR target value. And then the orange bars are compounds where there's an exceedance of the ecological safe value. There's obviously a lot of information on that graph, but I'll just beam in on a couple of the points. So if we look at, in terms of the continent that has the highest ecological risk, that's Africa, and sulfamethoxazole in Africa in 33% of the samples obtained from Africa, the concentrations of sulfamethoxazole were higher than the predicted no effect concentration for that compound. In terms of antimicrobial resistance, the continent that seemed to have the greatest level of exceedance of the safe targets for antimicrobial resistance was Asia, and ciprofloxacin was actually the most risky compound, with just under 15% of the samples taken across Asia having concentrations of ciprofloxacin above the safe value. Now, when the collaborators collected these samples, what we asked them to do was develop lots of notes on the characteristics of each of the sampling sites. So we don't just have data on the concentrations of the pharmaceuticals at these sites, we also have information on the characteristics of these sites. And what that allows us to do then is begin to look at what the potential drivers of the high levels of pollution might be. And the results of part of that analysis are shown on this slide. So the word cloud there, which basically is highlighting some of the terminology that was noted in the notes made at some of the more contaminated sites. You can see it includes words such as waste, sewage, rubbish, septic, hospital, manufacturing is in there, and industrial is in there. But when we begin to look at the most contaminated sites, what we tend to find is that many of them are in areas where you have political instability. Many are in areas where you have very high population density, such as Hong Kong and Delhi. Many of them, and you'll see this in the slides that I'm going to show in a moment, are associated with areas where you have low sewer connectivity and poor waste management or inadequate sewage treatment. So while they have the treatment there, perhaps the treatment's not working as effectively as it could. And we also have some climatic drivers sitting behind the data. Now, in the last few slides, what I'd like to do is just show you some photos of some of the more polluted sites. So this was one of the sites that had the highest concentrations or highest exceedances of concentrations of antibiotics. This was a site in Bangladesh. So you can see here the collaborator taking the sample from that site. You can see some houses alongside the river. Now, just behind those houses is a manufacturing area, so that we think that the high concentrations that we're seeing at this particular site are down to inputs from manufacturing. This is one of the contaminated sites, or most contaminated sites, that we saw in Africa. So this was a site in Nairobi in Kenya. You've got a photo of the site at the top there, which actually looks quite rural, but that water has very, very high concentrations of a whole range of different pharmaceuticals. And we think the reason for this is if you move up the road from the bridge that photo was taken from, and move a little bit up the road and look, you see the picture at the bottom there. So these are exhauster trucks. So basically what's happening is these exhauster trucks go round Nairobi, emptying the septic tanks. And what we think is happening is they're using this area as a site of disposal for the waste into the river system. This is one of the most polluted sites, again in Africa. So this was in Accra, in Ghana. You can see an informal settlement in the background there with the river system in the middle. But in the foreground, what that is a waste dump. So what we think here is there's probably pharmaceutical waste being dumped into that dump, and that material then is migrating from the dump into the river. And then the last picture is a picture taken in Israel. So in the background there, you've got the wall separating the West Bank with Israel, and then you've got the river. So this is the Nablus River passing under the wall into Israel, and just the other side of the wall is quite a large city where effectively you've got untreated wastewater being discharged into that water body. And you can see from this picture is that water body has a very low flow, so you have very low dilution of that wastewater. And again, that water, very high concentrations of pharmaceuticals. So just to round up then, the pharmaceuticals that we use will end up in the environment. If we look at concentrations in rivers around the world, many of the rivers that we monitored had levels high enough to cause ecological impacts and to pose a threat to human health through selection of resistance. Most of the impacted sites were in the low and middle income countries, but that wasn't always the case. So we did see quite high concentrations in some European cities and also some US cities. But generally we see the worst levels in areas where you have poor waste and wastewater management and these industrial discharges. And I think we really need to begin to work globally to begin to solve this problem and so fix and bring down some of these concentrations. The last thing I'd just like to do is plug this project, which is a new UN Decade of the Ocean Science project. This is called the Global Estuary Monitoring Project. And what we're hoping to do in that project is begin to expand the work that we've done in the river systems around the world to estuarine environments and to a wider range of contaminants. So at that point, I will stop. And afterwards, hopefully I can pick up any questions that people have. Thank you.
Thank you very much, Professor Boxall. And as I have a glass of what is clean water in front of me, your slides, I hope, are doing the same for our audience, spurring action to ensure that we protect the critical drinking water and health of populations. And last but not least, and we will still have time for questions following Dr. Laura Vandenberg's presentation. And again, Laura is the associate professor from the University of Massachusetts in Amherst to talk with us on plastics. Welcome, Laura.
Hi, thanks for being here. And a lot of what I have to say, you've heard a very similar message from some of our other speakers here. So hopefully some of those big picture messages can kind of sink in a little bit. I'm going to focus more on plastics in the medical setting and thinking about the ways in which plastics may be affecting human and environmental health. So plastics are all around us. We're producing around the world more than 270 million metric tons of plastics every year. When I saw this figure, I think the part that was the most horrifying to me is really this portion down here at the bottom, which is really highlighting to us that the whole idea of recycling plastics, while a great idea in theory, is really not taking care of the fact that we're producing massive amounts of it, and very, very, very little of it is actually being recycled. So a large amount of the plastics that are being created, not just in the medical setting, but for all kinds of consumer goods, are either being incinerated, they're ending up in landfills, or they're being mismanaged, including ending up in our oceans. This is a very serious issue that's really only started to get attention in the last few years by the general public. So there's a lot of different chemicals that are added to plastics, and in particular, plastic medical equipment. These chemicals are usually added intentionally as a way to provide certain kinds of features to those plastic products. So for some plastics, we want them to be hard, rigid, shatter resistant. Others, we want them to be very flexible, to bend, or to be very resistant to damage or to dirt. In order to create those properties, there's a lot of chemicals that are used and intentionally added to plastics. There's also chemicals that are unintentionally found in medical equipment, just the same way that they're found in food and food packaging, because of the way that that products are produced. We know already that plastic waste is contaminating all of the different matrices in the world that we depend on for human health. So we're finding plastic waste in soil and water, in air, and in the food chain. Microplastics have been documented in human bodies. So we know in many cases, this plastic is actually entering our body, but also the chemicals that are found in plastics are very easily migrating out of those products and into our bodies as well. And this heavy reliance on plastics has already been demonstrated to harm human health. And what I'm going to focus on today comes from my training in endocrinology, which is that there are many chemicals found in plastics that have hormonal activity. Other chemicals that are found in plastics that don't mimic hormones, but can block the actions of hormones in the body, or can change the way that hormones are synthesized by endocrine organs in the body, or alter the way that other organs in the body metabolize and excrete hormones. All of these together are referred to as endocrine disrupting chemicals. And in my lab, I've been particularly focused on endocrine disrupting chemicals that mimic estrogens, even though that world of endocrine disruptors is actually much larger. So we encounter endocrine disrupting chemicals in the medical setting in a lot of different ways. And I want to echo what you heard earlier from Darota about this idea that we should be thinking about these chemicals and the use of these products in the occupational sense. So the clinicians, the custodial services, the nurses, anyone who's involved in patient care who are exposed to these chemicals through the use of different products. There's also the manufacturing of these products. So other occupational settings that are outside of the medical center, but to produce these products so that they can be used in the medical center. We're also, of course, worried about patients' exposures to these endocrine disrupting chemicals through the use of products or equipment. And then, of course, we're also worried because a lot of products that are used in the medical setting are intended for single use and are then being disposed of and are potentially contaminating the environment as well. So we can see that there's endocrine disrupting chemicals in equipment, in hard plastics and soft flexible plastics, in absorbent materials, papers and fibers. A lot of the things that have the appearance of being fibrous are actually still made out of plastics or contain plastics. We're also exposed to endocrine disrupting chemicals through drugs, as well as through the coatings, the inert or inactive ingredients in drugs, and also in detergents, in lotions, and other personal care products that are very commonly found in the medical setting. Of course, I'm going to focus here today more on the plastics. I just want to make sure that you're aware of this big universe of endocrine disrupting chemicals that are potentially affecting both patients and providers in the medical setting. So before I get too far, one of the things that I often hear, especially in talking to the general public, is this idea of we're all exposed to these things and we're all fine. And I just want to remind us that actually we're not fine. And again, from my perspective as an endocrinologist, we have documented that there are increasing disease trends that have been seen over just a few decades in a lot of different conditions. On the left, seeing that the age at which young girls first reach menarche has declined over a period of time. On the right, showing that sperm count collected from populations around the world has declined over this a period of just about 2 generations. We've seen increase in the incidence of testicular cancer and breast cancer in women over just a few generations. An increase in the incidence of autism, ADHD, and other kinds of neurological conditions in children. Obesity and both type 2, which we think of as more of a lifestyle focused disease, but is also type 1 diabetes, seeing an increase in incidence in populations around the world. So this increase in disease and disease risk over relatively short periods of time where genetic changes are extremely unlikely is really pointing us towards effects that are coming from the environment. And yes, of course, changes in human lifestyle, changes in exercise and diet over time are contributing to these diseases, but that really can't account for the entirety of the story. And this is why researchers have been focused on other environmental factors, including the role of endocrine disrupting chemicals in many of these diseases. And while I don't have a lot of time to get in depth into the kind of data that have come from laboratory animals and human studies, there are many, many resources that are available, and I can put some references in the chat at the end here that suggest that these environmental chemicals, including chemicals that are found in medical equipment, medical materials, and other products that are used in the medical setting, can induce many of these diseases that are increasing in incidence in human populations. So I'm going to just quickly go over some of the different categories of chemicals that are found in plastics, including plastics that are used in the medical setting. The first category are chemicals that are used and added to plastics as a way to stabilize them against damage from UV radiation. So these are very commonly added to plastics, including hard plastics that are used to contain products that we don't want the product that's stored in them to break down based on UV damage. One of the most concerning is this chemical that's referred to as UV328. It was recently proposed to be added to the Stockholm Convention based on the fact that it has some of the characteristics of persistent organic pollutants. It is being found widespread in the environment. It does not break down easily in the environment, and it does have toxic effects, including endocrine disrupting properties, such as anti-androgenic behaviors. Another chemical that's received a lot of attention, and in fact, I spent the first 10 or 15 years of my career focused on, is the chemical BPA, which is used in a lot of different consumer goods, including the linings of food and beverage containers, consumer plastics, thermal paper, but also widely used in sports and medical equipment. And again, it's added to those plastics because it helps to make them shatter resistant while still being see-through. And the effects of BPA on hormone sensitive outcomes, including the reproduction, development and disease and function of the mammary gland, metabolic endpoints, the development of the brain and neurological behaviors, these are all very well documented. They've been demonstrated in controlled animal studies, and there's also significant associations that have been shown in more than 100 human studies. But we're learning that BPA is really just the tip of the bisphenol iceberg, that as BPA has been phased out of some of these products, other bisphenols with similar chemical structures have started to be added instead. And these BPA substitutes, so this is the chemical structure for BPA on the far left, on the right. In the middle is the structure for bisphenol S, which is a very common BPA substitute. And work from my lab has shown that BPS has many of the same effects as were previously documented for BPA. So we've seen effects on the mammary gland, the breast tissue in rodents that have been exposed to very low doses during early development. We've seen effects on the ability of mothers to lactate and to produce sufficient milk throughout the lactational period. Again, these are effects that we've seen in mice. In some animals, we see behavioral effects that are consistent with anxiety-like or hyperactive behaviors. This is a female mouse that was exposed to a very low dose of BPS only during early development. This is the kind of anxiety-like behaviors that she demonstrates in adulthood. So this backflipping behavior, which has absolutely no purpose, but is something that she spends hours a day doing. Another class of chemicals that's received a lot of attention are the phthalates. These are chemicals that are widely added to plastics and PVC products as a way to make them flexible. So they're very commonly found in medical tubing and in other medical equipment. The problem is that phthalates affect the ability of cells to make hormones. Largely, effects have been demonstrated on androgenic outcomes because phthalates reduce the ability of the testis to produce testosterone. But phthalates have also been linked to other diseases, including conditions affecting thyroid hormone, as well as metabolic diseases. The alkyl phenols are commonly added to plastics because these are chemicals that allow them to create barriers so that liquids bead up on those plastics. So they're sort of a surfactant. This is why they're also added to a lot of detergents and industrial cleaners. The alkyl phenols have been linked to male infertility and decreased in sperm count. They affect the ability of both cells, people, animals, and some documentation in human populations that exposures to alkyl phenols reduce the production of androgens and can mimic the actions of estrogens. There's also perfluorinated chemicals or perfluorinated compounds. These are referred to as forever chemicals in some instances because they really don't break down in the environment. They've been widely added to plastics, and they're found in a lot of fibers and upholstery materials, but they're widely used also because they can be added to materials to reduce stains. So they're added to carpets, they're added to paints. They're also found in cookware and in firefighting foams. They have been demonstrated to alter immune system responses, to affect the growth of fetuses and neonates, to alter the timing of puberty, and to increase the risk of certain cancers. And the last group of chemicals that I'll just briefly talk about are brominated flame retardants. They're added to plastic products, especially those that are used around electronics. They're also used in the electronic materials themselves as a way to reduce the risk of fire. They're widely used also in plastic children's toys, and they're found a lot in recycled plastics. Plastics, especially those very dark colored plastics, so some of the black colored plastics, often contain brominated flame retardants. And these have been demonstrated to affect neurodevelopment, including IQ, learning, and memory. They alter the actions of thyroid hormones and also can disrupt male and female reproductive development. So in a very short period of time, I can only present to you a limited overview, but there is a lot of evidence and a very strong case that chemicals found in plastics that are used in the medical setting, as well as plastics that are just used in our general lives, as well as other medical products, can impact human health. This occurs even when exposures appear to be low. There is documented causal relationships from animal studies, as well as correlational studies that have been done in human and wildlife populations, and that they link these chemicals to many diseases that are increasing in prevalence in human populations. And of course, we should worry about this because the production of plastics, by data that have been produced by the plastic manufacturers, suggests that production is only going to go up over the next several decades. So the production of plastics is likely going to continue, which means that we need to deal with these both in the event of how people are directly exposed to them as these products are used, as well as these products are disposed of. A lot of what I've just told you about is a quick summary from this report that was published in late 2020, in December 2020. It was a year-long collaboration by scientists with the Endocrine Society, as well as IPEN, the International Pollutants Elimination Network. IPEN involves 600 public interest GMOs in more than 120 countries around the world, largely low and middle income nations. And IPEN is really working to strengthen global chemical and other waste policies. And I'll put these links to this report in the chat box when I'm done. I want to thank the other co-authors of that report and wrap this up so that we can get to any of the questions that you have for myself or the other speakers. Thanks for the opportunity to be here.
Thank you very much, Laura, for the presentation and for all of the information. We have quite a number of questions that have come in, so I'm going to get right to it if I can now find them. Yes. The first question is for Aleister. In fact, it's a combination of questions that have come in for you related to the concentration of active ingredient in effluent compared to concentrations from healthcare setting effluents and from municipal sewage, as many regulators have identified hospital effluent as the place to regulate. And can you comment on where the relative concentrations and what are the highest contaminated waters that are effluent dominated?
Yeah. Okay. So unfortunately, it's not a simple answer. So there are sites that we've monitored where we monitored downstream of hospital emissions. So those were direct hospital emissions into the river where concentrations were high. But then there are other systems, and we've done stuff in the UK where actually the hospitals are discharging into the main wastewater system, and their contribution overall compared to the other emissions from a city is actually not as big as people might expect. So I think it's very situation dependent. In terms of I saw that there was a question about whether everything's down, the high concentrations are down to effluent dominated sites. Again, it's not as simple as that. So the sites where we tended to see the highest concentrations were associated with a whole range of potential drivers. So there were quite a few areas where there was manufacturing of drugs, and we think the high concentrations were probably down to the manufacturing processes. There were areas where untreated sewage was being discharged into the river system. There were areas where there might have been a wastewater treatment system, but it wasn't working properly, such as the site that I showed in Israel. And then there's this whole area of waste dumping. So a number of the sites had these exhausted dumps. And then you had landfill sites, so unlined landfill sites, but you also had general littering. So there were some of the sites in Nairobi where you just had tons of litter alongside the river, and our suspicion is that in that waste you had pharmaceutical stuff. So it wasn't like a waste in itself, it was just general littering with waste. So it's not just one source, and it's very situation specific, I would say.
Thank you. And I'm going to move on to some additional questions and ask the responses to keep short, because I think we have 6 or 7 minutes left. And perhaps if the speakers are willing, we can provide written questions to be shared later. A question for you, Laura, is are plastic materials that are less problematic than others, and what would this mean for sustainable procurement criteria? And an additional question for you is, if a Cochrane review evaluated the association between environmental exposures to plastic additives and human health effects were to be performed, what would be the level of evidence, in your opinion?
Okay, I'll start with the first question, which is procuring safer materials. There was a study that was published a few years ago from Russ Hauser's group at Harvard Medical School, where they went to 2 different hospitals and looked at babies in the neonatal infant care unit. And one of the hospitals had taken efforts to purchase medical equipment that did not contain phthalates, BPA, and a couple of chemicals. The babies had very similar health outcomes. So being in hospital A versus hospital B, they had similar success rates. They had similar time to discharge. And yet the exposures to the babies in the hospital that had taken active steps to avoid these chemicals were significantly lower. So you can have the same healthcare that's provided while avoiding these chemicals. And I know that there are some in the United States, some large purchasing groups that are working to try to avoid some of these chemicals in the medical setting. That doesn't mean that it'll be easy. It doesn't mean that the medical equipment will cost the same amount. That's sort of beyond my my level of expertise. But there are, we don't have to compromise patient care by avoiding using many of these chemicals. The second question was about the Cochrane review, which I think is great. We're starting to see that there are systematic reviews that are looking at the evidence for these various chemicals. To ask sort of the big question of like, how do EDCs in the medical setting contribute to harm? I'm not sure that specific to the medical setting we can answer that question yet, because people's exposures are not limited to the medical setting. And even, if you were looking at one chemical, we would be worried about their exposures before they entered the medical setting, which, we're exposed to BPA and phthalates and parabens and alkylphenols in our everyday lives. But there are systematic reviews that have evaluated many of these chemicals, but for the most part, they've looked at them one at a time, or a class of chemicals at a time, as opposed to looking at, plastics additives as a whole, because plastic additives as a whole, you would have to do probably, I don't know, 100 or more than 100 baby systematic reviews and then sort of add them all together. I do think that for some of these chemicals, the evidence is quite strong, and the studies are done well enough that as a whole we can conclude that there's harm coming from these chemicals, and that's been the consensus that's come from other scientific groups and bodies, including experts at the Endocrine Society.
Thank you very much. And Carolyn, I see your hand is raised, and I also want to call attention for the participants to the comments in the chat related to medical student and other health professional education with questions and responses. So thank you for the participants, and to Andrea Rother for starting that conversation. Carolyn.
Yes, thanks very much, Susan. It was a very interesting discussion. I wanted to mention a review that WHO did with UNEP, well, first of all in 2001 and then in 2012 on the state of the science for endocrine disrupting chemicals. And I think that one of the things that probably hasn't changed, even though another 9 years has passed, is that there are an enormous number of chemicals which you might consider, if you look at the WHO definition, as endocrine active. Their potential and have the potential to disrupt the endocrine system. And then there's another group of chemicals where there has been a link between the potential and actual human health effects. And what we found is that it's the second step that's incredibly difficult to get good studies. Certainly a lot more research is needed. There's a big difference in the number that have been proven to have adverse health effects and the number that are suspected. And this is really just not acceptable. We do need to have a lot more work in this field to address the issue, find out what the evidence is, and take action. Thanks.
And while you're speaking, Carolyn, a couple of questions have come in to you in terms of both what is WHO doing in terms to advocate for or document issues related to harmful chemicals and plastics and other equipment, and a related question, but related to the pharmaceuticals. You spoke about the essential medicine list and quality and safety standards. Are there activities that WHO is pursuing to look at the environmental aspects, like the Swedish environmental classification of pharmaceuticals for persistence and bioaccumulation?
Susan, there's 10 questions in there, and we're at 5:30, but I'll make a start. So in relation to the medical devices, we run a medical devices regulators network and forum that enables the device regulators, which are in each of the countries, to share information. One recent publication, for example, was a guidance document on the safe, I forgot what the word is, the title, but it's about how to remove the devices from their life when they've finished their life service. So disposal of those devices. So there's one guidance document that's been produced recently. In relation to, there's another question about the medical training, and WHO has been working with Nice University to trial some modules for training doctors about chemicals. So there's just a couple of the questions answered that you've posed. Thanks. Susan, you're on mute.
Someone did that too. Thank you for pointing that out. And thank you again to our 4 speakers, to Carolyn Vickers from WHO, from Darota Napierska from Healthcare Without Harm Europe, Professor Aleister Boxall from York University, and Laura Vandenberg, from the University of Massachusetts. I have on screen, as Carolyn referred to earlier, the Berlin Forum on Chemicals and Sustainability, which begins tomorrow with the ministerial dialogue and the WHO Director General. On the day following, there will be a stakeholder dialogue. You can register by looking at the link here, and we'll put it in the chat. I also wanted to draw your attention to the fact that SAICM is in the process of surveying participants and those who did not participate in the virtual working groups leading to the successor agreement to SAICM to gather views. And if you did not participate and were aware, I think it would be very, very useful to the Secretariat and to those of us on the Bureau to understand what the challenges were in your participation. I want to thank the organizations that contributed to this session, including the Swedish International Development Cooperation Agency, the Federal Environment Agency in Germany, the Ministry of Environment of Germany, the Life European Union Life Grants, and the United Nations Development Program. Thank you all for your participation, and I look forward to further dialogue. This was really interesting and useful. Goodbye all.